Hello, everyone, and welcome to NCSL's webinar on COVID-19, Ensuring Financial Stability of Healthcare Facilities. My name is Kelly Hughes, and I'll be moderating today's webinar. I'm a program director with NCSL, and I focus on policy issues related to healthcare access, costs, and coverage. Today's webinar is a platform for information exchange and engagement. We encourage your participation through the chat box, so please feel free to submit your questions at any time in the chat box, which should be in your lower left-hand corner of your screen. To get us comfortable with the chat box and to also learn who's on the line today, please submit the state from which you are joining us in the chat function now. I also want to briefly mention the Resources tab on the webinar platform. Above the presentation, you'll see several tabs, one of them labeled Resources. Here is where you can find and download a PDF version of the PowerPoint slides for today's presentation. You should also see a tab labeled Speakers. Here you can read the bios of today's speakers. You can access these tabs at any time during the presentation. Today's webinar is being recorded and will be available on NCSL's website within the week. And thanks to those who are submitting their states through the chat function. I see that we have representation from states all over the country, and we're glad that you joined us today. So for those who are less familiar with NCSL, the National Conference of State Legislatures is a bipartisan membership organization that serves the legislators and legislative staff of all 50 states, commonwealths, and territories. NCSL provides research, technical assistance, and opportunities for policymakers to exchange ideas on the most pressing state issues. And NCSL is also an effective and respected advocate for the interests of states in the American federal system. Before we jump into today's program, I'd like to briefly highlight a few NCSL resources available to you all related to COVID-19. NCSL maintains a web page to house our comprehensive resources on the state and federal response to COVID-19. To access this web page, you can go to NCSL's website at ncsl.org. You'll see a banner at the top. Click the banner that says NCSL Coronavirus Resources for States, and it will take you to the web page. Here you can find resources for state legislators and staff on topics ranging from continuity of government to health and fiscal to criminal justice and more. Additionally, today's webinar is the final in a four-part series on COVID-19 and the U.S. healthcare system. If you missed the other webinars, you can access them on the NCSL Coronavirus Resources for States webpage that I just mentioned. And we'd like to thank the Commonwealth Fund for their support of this webinar series. So now let's get to the program. While the COVID-19 pandemic has challenged the medical surge capacity of healthcare facilities in hardest hit areas, it's also challenged the financial stability of many healthcare facilities. Several states have suspended or postponed non-emergency services, which is a major source of revenue for healthcare facilities, and are facing other factors impacting expenditures and revenue. Today, we will explore federal and state actions and strategies for mitigating the financial impact of COVID-19 on healthcare facilities. Our first speaker, Haley Nicholson, Senior Policy Director of Health and Human Services State Federal Affairs in NCSL's DC office, will provide an overview of federal legislation related to healthcare facility emergency funding and supports. Then we will hear from representatives of two national organizations representing healthcare facilities. Molly Smith, Vice President for Coverage and State Issues Forum at the American Hospital Association, will speak on the impact of COVID-19 on hospitals, and Jeremy Crandall, Director of State Affairs at the National Association of Community Health Centers, will speak to the impact of COVID-19 on community health centers. Finally, we will hear from Minnesota State Senator Michelle Benson, who will share her perspective and discuss legislative actions taken in Minnesota to support healthcare facilities. And so with that, I will turn it over to Haley Nicholson.
Great, thank you, Kelly. Good afternoon, everyone. As Kelly said, I work for the State Federal Policy Team for NCSL, and I'm going to provide an overview of federal funding that has gone out over the past several weeks for healthcare facilities. Here are the different topics that I'm going to cover with a focus on the Public Health and Social Services Emergency Fund and congressional administrative actions around that fund. So first up, congressional legislation. The Coronavirus Aid, Relief, and Economic Security Act, also known as CARES Act, became law on March 27th. Within the bill was dedicated funding for healthcare facilities and providers, also referred to as the Provider Fund. Of the $127 billion that was provided for the Public Health and Social Services Emergency Fund, $100 billion of that was for grants to hospitals, public entities, non-for-profit entities, Medicare and Medicaid enrolled suppliers, and institutional providers. The funding is provided to help with unreimbursed healthcare related expenses or lost revenue as a result of COVID-19. As many may know on this webinar, facilities have canceled elective procedures and a majority of routine medical care to build up the capacity for COVID-19, but also to decrease the risk of unnecessary patient exposure. Within this funding, there was also resources allocated for supplies, manufacturing, and equipment, varying amounts for different programs, and those are listed at the bottom of this slide. Additionally, in the CARES Act, there was also funding $215 million to improve the capacity of facilities in order to respond to medical events, and also $275 million to expand services and capacity for a number of entities, including rural hospitals, telehealth, poison control centers, and the Ryan-wide HIV/AIDS program, and with the funds going through the Health Resources and Services Administration, also referred to as HRSA. The bill also included community health centers to use fiscal year 2020 funding to maintain or increase staffing and capacity to address COVID-19. Now, following the CARES Act, another package did come out, and this was passed a few weeks ago. This is known as the Paycheck Protection Program and Healthcare Enhancement Act, so focusing on two very specific parts of the CARES package. In regards to the Healthcare Provider Fund, this provided an additional $75 billion for the fund, used for the same purposes, and it also included additional set-aside funding of $600 million for community health centers and federally qualified health centers. This also included $225 million for rural health clinics and $6 million for the HHS Inspector General for oversight of all the bill's funds. So a lot of different moving parts and funding going out to a number of different facilities and different settings. I also want to give a quick note. Some may be aware that the House released a fourth stimulus bill package yesterday, also known as the HEROES Act or HR 6800. It is a 1,800-page bill, and NCSL is working to review that bill to pull together a summary, but we also acknowledge this is not negotiated with the Senate. It's not a final document for what could ultimately be included in the fourth bill, so we will provide a summary knowing that this could very much change and the process could change in what happens on a fourth bill. So just wanted to give a quick note on that. We'll go back to provider funding movement that's been happening with current legislation that passed. So after the passage of the CARES Act, HHS awarded $30 billion from the fund to providers, with funding going to those who are enrolled in Medicare. The facilities and providers were given funding based on their share of 2019 Medicare fee-for-service reimbursements. This method did receive some pushback, as the payments, some felt that they were overlooking the more vulnerable facilities that treat high proportions of Medicaid enrollees, those that are located in rural areas, and other providers that may not be experiencing the same volume of COVID-19 cases as other areas, but they've lost a lot of needed revenue with the cancellation of elective procedures. So after this initial $30 billion went out, it was also announced last week by HHS that hospitals and clinics can receive an extra 15 days to confirm if they have received this first round of funding. This will give providers until May 24th to confirm a receipt of funds that went out on April 10th, giving them overall 45 days to sign off on the terms and conditions for the federal money that has been allocated and out and is still going out in some cases. Now, in the interest of time for these next few slides, I'm going to go to the further breakdown that HHS has released on Provider Act funds. And some of this has taken into account, again, what I mentioned earlier, some of the pushback in that initial funding going out based on Medicare fee-for-service reimbursements. And so as I click through, if you have questions, please feel free to put them in the chat or for Q&A. I'm happy to answer, to follow up on these amounts or anything else. But again, with all these great speakers, I want to be sure that we give everyone the time that they need. So HHS broke down the funding by a few different categories, including general and targeted allocations, uninsured populations, as well as allocations for rural providers and an allocation for the Indian Health Service. All of these categories, as you can see when I went through the slides, are different funding amounts and deciding criteria, but HHS has a similar aim to get funding out to all of these groups as quickly as hopefully this week. And so that is just a quick overview of some of the funding that has gone out as a result of congressional legislation, administration movement. Here are a few different resources I recommend looking to follow up, and these also include resources with allocations to your states and what your states have received and what facilities in some cases. And that's all I have. Thank you so much, and I'll turn it back to you, Kelly.
Thanks so much, Haley. So if there are any questions, please feel free to type those into the audience chat box. We have time to take one or two burning questions, but if there are none, then we will move on to the next presenter and have time at the end for questions. So with that, I'll turn it over to Molly Smith from the American Hospital Association.
Great. Thank you so much, Kelly, and thank you for all of you for having me. I really appreciate your interest and support in ensuring that hospitals and health systems are able to continue caring for all of our communities during these just incredibly unprecedented times. So I thought I would spend a little bit of time talking about the situation, the financial situation that hospitals find themselves in. We're really sort of facing a triple threat. Two of these at least have already been mentioned, but just to put a little bit of a finer point on it. So the first is really the cost of kind of building capacity to care for COVID-19 patients. I think you've probably seen a lot of this occurring in your communities. There are building of new wings. There's retrofitting of space to sort of contain patients to minimize the spread of the virus. There is securing the personal protective equipment for staff. There is actually getting more staff and moving them all around the country. At the same time, there's already been mention of the reduction in care that's occurring, and we often refer to this as sort of reduction in elective procedures or non-emergent, but that's actually not entirely the full story. There has been a reduction in services largely across the board if it's not COVID. I mean, even emergency services are down. In many instances, that's because of positive things of health. There's less trauma, there are less cars on the road, less car crashes. Pollution flare-ups for certain diseases are down. So some positives, but it's also meant just a dramatic shift in what hospitals and health systems had prepared and staffed and supplied up for versus what they're actually seeing and getting reimbursed for. The final piece is around investment losses. So you probably hear often that many hospitals are operating in the red. In fact, the government itself has projected that upwards of 40% of hospitals in the next few years will be operating in the red. The way that they often have stayed open while operating in the red is that they have relied a lot on their investment income to help supplant or add to their operating revenue. And with the markets as they are right now in the economic downturn, their investments are not immune to those. And so you see just sort of all of these things sort of really putting the financial pressure on hospitals. And what that ultimately means is that they really struggle to maintain their workforce, to purchase supplies. Many are concerned about violating their bond covenants, thus triggering further financial stress. And in some instances, we have already seen hospitals close altogether. So the AHA has been monitoring and working with our members to better understand what's happening. We did just recently release an analysis that looked at the financial impact of this period on hospitals and health systems. It does not account for everything. It was really just a 4-month period. We looked at COVID-19 hospitalizations and treatment costs. We looked at canceled and foregone services, the acquisition of some of the supplies like the PPE, but also hospitals have really had to step up and provide a range of services and benefits to employees just so they can come to work. So childcare because schools are closed, transportation because it's not a good idea for them to necessarily be on public transportation with their exposure level to the virus, housing so that they're not bringing it back to their families. So there are a lot of costs like that that are being borne right right now by the healthcare system. So as you can see here, for that 4-month period, we estimated it's about $200 billion in cost. And again, this does not account for everything, but roughly translates to about $50 billion a month. So did just want to point out that, of course, there are some organizations, some hospitals and health systems that were already very vulnerable coming into this situation. And so this just further exacerbates their financial situation. Rural hospitals are not the only ones, but they are a class of hospitals that have just, really struggled with just a number of issues that kind of make their financial situation more precarious. You can see some of those things on this slide, but they've long struggled with low patient volume, high cost of acquiring equipment and supplies, challenges with recruiting and retaining clinicians and other personnel. So you can imagine that something like COVID-19 that is, creating a dramatic hit to their revenue, as well as putting increased demands on them to build up capacity, has been particularly hard for this group of hospitals and health systems. So I'm not going to belabor this too much because I think Haley already did a great job laying out what a lot of the federal resources that have been provided, but I will just hit on a couple of the key ones for hospitals and health systems. There's a couple on this slide. It's really the first two that I will focus on. So it's the emergency fund as well as the accelerated payment option under Medicare. So if we look first at the emergency fund, again, Haley already went through a lot of this. $175 billion has been authorized to date. $72 billion has been distributed. As she mentioned, there's been a series of waves and ways in which they've tried to target the money, some general allocation, because I think part of the intent of this money was just to preserve providers and keep them, financially alive and viable during this time period. And then some of this was really, of course, to help pay for the additional cost of COVID. And this has really just been absolutely crucial in helping providers stay open. But, as Haley mentioned, there's definitely been some concerns about some of the allocations. I think at first there, of course, was the general distribution. They were just trying to get the money out quickly, which we can fully appreciate. But it wasn't targeted, for instance, to those organizations that had, were in hotspots, basically. So that hotspot distribution did come, but even then, there's a point in time at which they need to make a decision about where a hotspot's occurring and establish some thresholds. So, of course, it wasn't able to accommodate everyone. Just so you know, the threshold was having at least 100 cases of COVID-19 treatment, and the cutoff date at that point was April 10th. And, we know that there's a lot of places that are peaking that either did peak after April 10th or still have yet to come. And, HHS is aware of this. So I would expect in the future that there would continue to be some consideration for hotspots and getting resources to those areas as they emerge. Similarly, as Haley mentioned, there has been a lot of discussion about what about the providers who primarily serve Medicaid or other vulnerable populations, and have they been sufficiently accounted for? These could include hospitals and health systems with large percentages of Medicaid or the uninsured, but they also include providers like dentists and behavioral health providers and pediatricians. And we do understand that HHS is right now in the process of collecting data from states to try to better understand who these providers are, what services they provide, and sort of their normal funds flow, especially from the Medicaid program. So again, we do expect there to be some more tailored distribution for these providers moving forward. And again, I think that what we understand, HHS is struggling with is making sure that we both target the money, which takes time, but also get resources as quickly as possible because they really are needed now. So we really do appreciate that this is a real challenge, and there's just no perfect way to do it. The next thing I did just want to hit on was this portion of that money that is going to be dedicated towards reimbursing some claims for the uninsured. So there was some specific money set aside for testing for the uninsured that is actually above and beyond the $175 billion fund. That's $2 billion from two of the pieces of legislation. But for claims for treatment, those are really just coming out of that same pot of money, that $175 billion, of which, again, a portion of it's already been spent. The thing that I wanted to point out here, though, is that, of course, HHS had to establish some rules for which claims they would reimburse. And we actually have a fair number of concerns that many claims for the uninsured actually will not be eligible for reimbursement through this program. There are two kind of policy decisions in particular. One is the way in which they define uninsured. So, for example, if an individual is in a short-term limited duration health plan, that, for instance, may not even cover inpatient services because these are not plans that have to meet all of the sort of consumer protection criteria of other plans. So they may not even have inpatient coverage, but for HRSA's purposes for this program, they will be considered insured, so their claims would not be reimbursable. Similarly, they're not reimbursing for claims where COVID isn't the primary diagnosis. The challenge here is that many patients who have COVID and are getting treated for COVID-19 aren't going to have COVID as their primary diagnosis. It's actually just the way the coding rules work. So a good example of this is you have a patient who comes to the hospital, they have sepsis. It turns out that COVID-19 is the underlying condition that's caused their sepsis. They then go for treatment. Of course, their sepsis is getting treated, but they're really getting treated for COVID-19. Under these rules, the coding rules, sepsis is the primary diagnosis, COVID-19 is a secondary diagnosis, and these claims would not be covered. So I think it's important as policymakers in your state to understand that this is not going to be a comprehensive solution for the uninsured. I am definitely not going to touch on everything that's on the slide. In fact, I'm just going to make a few quick points, but there is another kind of funding source that has been a real lifeline to hospitals and health systems, and that has been the Medicare Accelerated or Advanced Payment options. These really, though, are not, they function like loans, not grants or sort of free money, and it really is just asking Medicare to pay you in advance for the services you expect to provide, and then you actually have to pay them back. And in fact, with pretty significant loan terms, right now the interest rate is 10%, which is, as you can imagine, quite high. However, this was a very, very, we talked before sort of about speed. This was a quick way for CMS to make funds available, and many providers did take advantage of this opportunity. We, though, are very concerned that now that we're further along in this, we're realizing that a lot of the care that has not occurred during this period is probably not coming back. It's not just deferred, a lot of it is foregone. So the ability of these providers to pay back this money to CMS on these terms is going to be very challenging. So we are currently asking Congress to convert these loans to grants and, in other words, make them forgivable. Looking ahead, because I know we need to wrap up and move to the next speaker soon, but looking ahead, I think, there's just so many unknowns that we need to be preparing for from a financial perspective, since that's really what we're talking about today. Obviously, we don't know where the next outbreaks will be and how severe they'll be or for how long they'll go on, given that it will be quite a while before we have a vaccine and sort of widespread delivery of that vaccine. Another thing that we are just, I think, at the very beginning of is the disruption to coverage. Obviously, we've already witnessed a lot just of dramatic job loss, and with that corresponding coverage loss. And as I think you probably are very familiar with, coverage is absolutely fundamental to having routine access to the healthcare system. And without coverage, this will really challenge our ability to contain the virus. But it also puts additional financial pressure on providers as they either see increased levels of uncompensated care, or an increase in Medicaid enrollment, which of course is, for hospitals, pays below the cost of delivering care. So thinking about some of the state opportunities, sort of beyond what the federal government is doing. First of all, I just want to acknowledge we know that you're already doing a lot, and this is pretty much all that anyone is working on. And so, but did just want to highlight a couple of areas that where we've seen some state action, that have been really positive. Oops, it looks like, sorry, I'm not sure if you guys are seeing this. The slides seem to be moving themselves, so I'm going to try to take us back. Okay, to this one. All right, so in terms of the state opportunities, the first is the CARES Act, of course, allocated $150 billion to state, local, tribal, and territorial governments. And we know that there's a lot of interest in how these dollars can be used, in many, many different ways. But one of them, of course, is to help support the healthcare system and potentially close any gaps that remain from, federal efforts. Another, of course, is around coverage. And I know the demands on state Medicaid programs are going to be immense. They probably already are. And so really looking at ways that states can help shore up the marketplaces or even help employers continue coverage and minimize disruption to individuals, so that you can try to protect, and your Medicaid programs to the greatest extent possible. So things like states are, opening special enrollment periods for the marketplaces, but also thinking about ways to provide additional subsidies to employers to maintain coverage. And then the final thing I'll just mention is looking at the private payers to step in and help more. I think that early on there was concern that the insurers were going to face some of the same costs and financial pressures that providers were facing because, of course, an expectation that they would be overwhelmed with COVID claims. I think increasingly as we're further along in this, more and more analysis and the profit reports from the large insurers have shown that actually the deferral of the non-emergent or sometimes emergent, and also elective services has actually resulted in more revenue, and that's more than offset the cost of the COVID claims. So increasingly, we're seeing states look to their private payers and working with them on how to use that money that they have within their premium dollars to really funnel it back, get it back into the healthcare system where they had always intended to spend it, but really right now don't have claims to spend it on. So things like requiring accelerated payments, requiring them to process claims quickly, breaking down some of the administrative barriers to care and to payment. So this is, I think, an area really kind of ripe for opportunity. So with that, I will pause and see if there are any questions at this point, or of course I will be around in case there are more at the end.
Thank you so much, Molly. I am looking at the audience chat and I don't see any burning questions at this time, but I do want to encourage the audience to submit your questions. We want your questions. We want to engage, and we will have time at the end likely. So please do submit those questions. But thank you so much, Molly. And with that, I'm going to turn it over to Jeremy Crandall from the National Association of Community Health Centers.
Great. Thank you, Kelly. Can you hear me okay?
Yep, we can hear you great.
Excellent. Good afternoon, everybody, and thank you for having NAC join this very important conversation. As Kelly mentioned, my name is Jeremy Crandall. I'm the head of state affairs for NAC. We're the national trade association that represents the 1,400 community health centers and their state associations across the country. Before I begin, I want to say a personal thank you to all the state legislators and staff on this call. I previously worked in the Maryland General Assembly for about 8 years. I can't imagine the level of concern and the amount of inquiries that you're receiving from your constituents, from the community, from all the various interest groups, including our own state trade association in your state that you work with on a daily basis. So I just want to start by saying thank you for all you're doing, because I know it is a lot on many fronts right now. So let me start by sharing a little bit about the community health centers, also known as FQHCs or federally qualified health centers. Again, there are approximately 1,400 health centers across the country, or health center organizations. We serve 29 million patients. We're in every major U.S. city. We're in small towns. We're in suburbs. We're in rural areas at 11,000 different service delivery locations. 45% of our centers and nearly 4,500 sites are in rural communities, where we serve 1 in 5 rural residents across the United States. It's so important to this conversation is the work that we do for the underserved. 1 in 6 Americans on Medicaid rely on us for their primary care. And so what does that care look like? What are we talking about? So our health centers take enormous pride in their ability to deliver the entire range of primary care services for our patients. We're talking about family, pediatric, and obstetrics medicine. We're talking about laboratory and vaccine services, dental and behavioral health care, which is obviously so critical, some substance abuse treatment, and then other critical social services. As many health policy advocates on this call know, and if you're on here as a state legislator or staff, you're certainly a health policy advocate. One of the best long-term solutions to improving health in this country outside of the COVID pandemic is treating the whole person. It's treating the whole patient. And our health centers are heavily focused on delivering that type of wraparound care that's focused on social determinants of health in a cost-effective way for every single patient. So let's get to talking about COVID. So right now, health centers are by no means the only part of our healthcare system that is struggling right now due to the COVID pandemic. We just heard from our friends from the Hospital Association who are doing incredible work under enormous amounts of stress treating the most severe of COVID cases. That said, it is absolutely no overstatement that due to a myriad of factors, many of our health centers in your states and across the country are really on the brink of closure as we speak due to a number of reasons. So let's look at that overall picture. Here's what it looks like. As the primary care provider for the underserved, our health centers are heavily reliant on the revenue from delivering day-to-day services for people on Medicaid and Medicare. Many health centers are experiencing severe declines in their regular primary and preventive care visits across that range of services that I mentioned, whether due to the social isolation directives, staff cuts related to the pandemic, the nationwide personal protective equipment, PPE shortages that we're all familiar with, the federal and state stay-at-home orders, and then finally expectations that non-essential medical services be delayed. Together, those are painting a dire picture, and the national numbers are a dire picture for our health centers. We're talking about 34 million fewer visits over the next 6 months based on the current trend lines, $7.5 billion in lost revenue. That equates to 100,000 jobs of folks that work in our health centers. And this is an important stat as well, that more than 10% of our staff today cannot work due to either a COVID diagnosis themselves or to treat a member of their family. So, national numbers, are critical, but they obviously don't tell the whole story. It really is on the ground in communities where the situation is most dire, where it is most real to you and your constituents. This is a brief state-by-state analysis that shows the impact, in your individual state, because no state or locality is immune from the crisis. I want to emphasize, I'm a bit of a chart geek. This chart is available on our NAC website, and happy to provide it directly to anyone after the webinar for you to take a closer look at it as it pertains to your individual state. So by now, everyone has heard a story about a health professional or first responder serving on the front lines. Here's 3 such health center professionals that I wanted to tell you about briefly. The first one is Dr. Christy Thomas from Miami Beach Community Health Center. She has said she knew it was just a matter of time before she would be infected with COVID, going to work every day. Thankfully, her case was mild. She recovered quickly, but her biggest fears were infecting her husband and being away from the health center delivering care for her patients. The next story, Dr. Cavasseri, who is seeing every day, he's from Ultimate Health Services in California, who's seeing every day that the social determinants of health, we're talking about food security, we're talking about housing, are just as critical. One of his patients has a son with a developmental disability. Her brother was diagnosed with COVID. They live together in a small apartment. And so how can they socially distance or quarantine, which we know is so critical in terms of preventing the spread of the infection? And then finally, Dr. Kimberly Betcher in West Virginia. She is the person on the far left in this picture. She is indeed wearing homemade personal protective equipment in this picture. She works in a state, as she will attest, like West Virginia, where, COVID can have severe impacts on people, where much of the population that she treats has existing medical conditions. All right, so despite all those challenges, despite that, very dire picture that I've painted, our health centers really are trying to do everything that we can to respond to the crisis at hand. Over the past 2 months, FQHCs have significantly ramped up their testing and COVID response capabilities. To date, we've conducted more than 350,000 COVID tests. 90%, 9 in 10 health centers now have the ability to either provide a test, and 2/3 offer walk-up or drive-up testing. Just as importantly, we're working hard to shorten the test result turnaround time. Obviously, folks want that result as quickly as they can. I really want to emphasize that this data collection is a top priority for NAC. We work closely with our federal partners, HRSA, which is a subsidiary of the federal HHS, which oversees the federal portion of community health center funding. They deserve huge appreciation for the work that they've been doing on collaborating with us. And we're going to keep staying focused on this data collection because it obviously is going to be a critical piece as we look to reopening. So I want to get to a few of the state level items. Some of it is going to dovetail a little bit with what Molly was mentioning. And where do we go from here? While there has been so much attention paid to the role of the federal government and Congress as it relates to the COVID pandemic, as everyone on this call knows, for me personally, as a state guy, as somebody who worked in state government, state governments and agencies are already playing such a critical role in responding now and are going to have a huge role in the future, whether you're in session right now or when you get to 2021 for the next legislative session. For health centers, that conversation absolutely starts with Medicaid. When half of the patients that walk through our door each day are Medicaid enrollees, when 1 in 6 Medicaid enrollees across the country count us as their primary care provider, it's obviously very critical to everything that we do. In the short term, there are a number of actions that states can take to ensure vulnerable residents and their providers are protected. So I want to start with several states have already submitted Section 1115 waivers that are requesting CMS approval to establish disaster relief funds. And there are also other critical tools that states can use to increase payments to providers, whether through their fee-for-service or Medicaid managed care MCO programs. These approaches, while technical, they're also narrow and build on approved payment mechanisms that very likely already exist in your state. These require CMS approval, but we've already seen, and I understand that you may have heard or had a discussion about Medicaid before this, and we've already seen that CMS has been very responsive to state needs during the pandemic. The whole purpose here is to address the reduction in utilization that we're seeing, because when fewer Medicaid patients walk on our doors, it has a direct impact on our health centers. Longer term, I know every legislator on this call knows what's coming down the pike from a budget perspective. I was a staffer during the Great Recession. My boss was on the Appropriations Committee, so I know the tough choices that you have ahead of you. What we ask you to remember as community health center, representing community health centers, is that your state's investment in healthcare now saves your state in the future. Our patients, more than most any other provider, will inevitably end up in more costly settings if they don't have the ability to seek affordable healthcare through Medicaid coverage. And finally, we'd also encourage you to look at codifying many of the innovations that states are already pursuing as we speak. That includes easing enrollment and eligibility standards, especially given the cyclical nature of the economy and Medicaid. And it also includes efforts to pay directly for non-medical social determinants of health interventions. So I got a couple more slides here and then I'm done. As we talk about innovation seizing the moment right now, there really is no better example than telehealth when it comes to the pandemic. The COVID pandemic, bear with me one moment. COVID pandemic is proof positive that telehealth works. It obviously brings care directly to patients when an in-person visit is not possible. That is really what we're all dealing with on a daily basis right now. It helps us treat the whole person, the whole patient, and it also helps with medical management. We're hearing from our health centers right now about how the ability to consult with a patient, for example, on their prescriptions while the patient is at home with their pills right in front of them, has helped immensely with care management. So as you return to your legislatures, please take a close look at your state's telehealth rules, whether through Medicaid or state law. Does your Medicaid program have comprehensive telehealth coverage for FQHCs, regardless of the site of the provider and the patient? How does it treat audio only when the patient cannot use Zoom or FaceTime? You can't imagine how many concerns we've had about the challenges associated with telehealth treatment for seniors and low-income patients because many of those rules require there still to be a video component. And then finally, how does private insurance treat telehealth? finally, we welcome your help on a federal solution on telehealth. There's considerable misalignment right now between Medicaid and Medicare rules on telehealth, and outreach to your federal representatives on this would be immensely helpful. So this is my last slide here. Lastly, a look ahead as it pertains to the health centers. Our health centers are doing their very best to fight COVID right now. We're doing massive community testing and want to be helpful with vulnerable populations as we begin to reopen. But I really can't emphasize enough, that's only possible with your engagement, with your support, with your help. I don't want it to be missed that the PPE needs right now are still extreme. Some of our FQHCs still only have approximately 1 week's of supply left of gloves, gowns, and masks. And this issue is actually very much driven by states and their governors. States have a lot of control over how that equipment is distributed. We need stable funding and policies that help us keep doors open and expand access to care. And then finally, as you weigh statewide plans on testing and contact tracing, that's obviously something that we're talking a lot about now. We strongly encourage you to ensure that the health centers in your state primary care association, which is that's the trade association for our health centers, are at the table for that work. So with that, in closing, since dogs are what's keeping so many of us sane right now, here's mine. His name is Monkey, and I'm more than happy to answer any questions. Thanks, Kelly.
Thank you, Jeremy. Looking at the chat function, we don't have any questions at this time, but please think about those awesome presentations and submit your questions, and we'll take them at the very end. With that, we have our final speaker of the day. Last but certainly not least, I am pleased to turn it over to Senator Benson to share more about Minnesota's experience. Senator Benson, the floor is yours.
Thank you so much for inviting me. And I will tell you, and I've been telling everybody this, I had early contact with a man who is a history major while he was in school, and he reminded me that in May of 1942, FDR hired a historian to start documenting what was happening during World War II. And while we are not in World War II, we are in an historic point in time. We are going to see this virus and be battling this virus in our healthcare system for the foreseeable future until we receive herd immunity, if that's possible, until a vaccine works, again, related to herd immunity, if that's possible. So think about what you're doing right now and take some time to document that, what is different about your life. And I just want to remind everybody, our humanity is what connects us, but as healthcare policymakers, we are at the heart of something truly historic, and the decisions we make, people will look at in hindsight, and they will be wrong, right, but document what you're thinking about and how you're feeling, because it will help you remember as we go forward and as this becomes part of history. So thank you very much for having me. Minnesota is a nation leader in healthcare. We are very proud of that. We, I don't know how many of you remember Lake Wobegon, but we believe everything here is above average. So if I sound a little proud and puffed up, it's because we really do have great healthcare here in Minnesota. Collaborative care is our practice. We have rural, urban, independent, and then system-wide healthcare through well-connected networks. We early on have divided our state into hospital regions where the leaders of those organizations regularly get together and coordinate staffing training, coordinate response plans, and that has prepared us for a time like this. We practice a lot responses. So in 2006, when the Republican Convention was here, they practiced for everything from a dirty bomb to bioterrorism, and our hospitals were all part of that, dispersing patients out to greater Minnesota from the metro, setting up one of our stadiums as a triage location. They practiced that. When the 35W bridge collapsed in 2007, that tested some of the current leaders we have now. Dr. John Hicks was the incident command coordinator for that, and he is the incident command coordinator here. He is trusted. and respected. And people have seen him walk through really difficult situations and make turn on a dime decisions that literally saved people's lives, but functioned within our healthcare system very well. Super Bowl 18, our public health lab really stepped up. Obviously, like most communities, we have radiation detectors throughout the city, but we practiced checking in on those radiation detectors more frequently. We had specific reserves for responses to bioterrorism. Our public health lab really honed its skills during Super Bowl 18, working with the CDC to prepare for major events like the Super Bowl and the Final Four. And so that practice of being coordinated and trusting in our healthcare systems, our hospitals, clinics, individual providers, and then this sort of multiple times being tested in our ability to respond and to prepare and respond for major events has prepared us for COVID in 2020. Not that things went great. There was some stumbling. Protective equipment, as everyone has talked about, was a huge issue, a level of uncertainty. But one of the benefits that I have in having worked in healthcare legislatively for this long was the confidence that our leaders would say, we don't know what's going to happen, but we think this is what's going to happen. And as politicians, it would be, or as elected officials, it would be much better for us to say, we don't know what happens next. Here's what we're watching for, instead of saying, well, this is the decision, and acting as though we know, because we don't. Doctors, epidemiologists, people who run hospitals have that humility to say we don't know what happens next. So we, as leaders, have to keep that in mind. We have a top-tier public health lab, as I mentioned, the University of Minnesota Medical School. Dr. Toller is a world-class transplant surgeon, but he started in immunology, and he now runs the University of Minnesota Medical School and the Physicians Group. He started thinking about serological testing in late February. That's how long ago he was making a plan. We also have Osterholm, who is a world-leading epidemiologist. He worked on the Arabian Peninsula with MERS. He follows SARS around the world. I actually had a phone call with him very early on. And then we have the Mayo Clinic. Everybody's familiar with them. And we regularly have a number of top hospitals. I misspelled Dr. Osterholm, so I had a meeting with Dr. Osterholm February 27th. And then the M. Fairview Hospital is one of 10 infectious disease hospitals. I had my first call with them February 28th. Their medical director had been deployed as a surgeon in both Iraq and Afghanistan, had done 5 deployments. He had a pretty good idea what this battlefield was going to look like, and was ready. Those 2 calls early on made me feel a little sick about what might be coming at us. And so we very aggressively started with help for our public health lab so that they could do early testing and tracing, so that they knew that we were going to have to develop new testing models. Those were included, making sure we had the right staff, that we actually started accumulating personal protective equipment. And then before March 17th, when we did shelter at home, we passed hospital and long-term care grants. Given what we had seen in Italy, we knew long-term care facilities were going to be at the very heart of this. And so hospital and long-term care facilities were treated very similarly. We did fast out the door grants for expenses they'd already incurred, and then longer-term grants that were focused on, for example, if they needed to convert part of their emergency department into a negative airflow space. That would be temporary and would come back after COVID, so they couldn't build it into their cost structure. We covered that. We gave extra money for training because, as you know, a nurse who works in the maternity ward delivering babies doesn't have to train on vents regularly. We started paying for that training early on. we started actively conserving personal protective equipment and paying for PAPRs and CAPRs, in addition to the world famous N95 mask made right here in Minnesota, by the way. We'll get to that in a little bit. But we also, it had been mentioned earlier, housing for staff as they were quarantined. When we went through Ebola, we actually paid for any staff that had been in touch or was assigned to an Ebola patient would have a separate hotel facility that would be outfitted for them so that they wouldn't have to worry about going home to their family. And so that Ebola experience paid off as well. We had trained donning and doffing. We had rooms where you could run tests with negative airflow and not have it vented. So we felt, with a little bit of support from the legislature in these $200 million grants, that we were doing everything we as elected officials could do, and then trusting the professionals to provide care. We set up a COVID account for the governor because if the legislature wasn't able to meet, we wanted some flexibility around that money so that Governor Walz could go out and make additional purchases that perhaps we hadn't foreseen, or in the event that hospitals were starting to have cash flow issues, could have support. Let me continue. And so there were regular meetings across the regions that we had talked about, and then there were a representative from each of those regions, daily calls to coordinate how full facilities were, what kind of ambulances were going to be designated as COVID ambulances, properly geared up with ECMO if needed for transport from Tier 1, Tier 2 to Tier 3 hospitals. We're very fortunate to have 5 Tier 3 hospitals in the state of Minnesota. That was all part of their plan. I mentioned 3M is in Minnesota is the only place in the United States that makes personal protective equipment. And when we couldn't get masks, I called the executive vice president who's in charge of masks, and they were having their supplies confiscated in China, and there was nothing they could do. They had people here working at the plant 24/7. They were trying to find ways that they could expand their manufacturing here in Minnesota, but you have to do all of that in an FDA-approved facility, and they just couldn't take the risk that those masks were going to fail to meet criteria. And so very frustrating. That all happened before the end of March. Like many of you, elective procedures were canceled, losses of $3.2 billion. Our healthcare providers had their salaries cut, nurses laid off. People didn't understand, if we're in a healthcare crisis, why are you laying off nurses? But really importantly, and as a public policy concern, care was delayed. So nerve blocks that could help prevent addiction were delayed. Mammograms that could detect early cancers were delayed, and those were only recently reopened. Continuing, our ICU and isolation beds are still slightly short of our projected peak. We have 1,000 more vents than we have ICU beds. If you talk to an ICU nurse, they're going to say, how am I supposed to vent somebody without a bed? And we're talking about if we hit peak, it doesn't look like we're going to overwhelm our system, but we would be doing 2 vents in one ICU room. Don't ask me. Doctors who run the medical response at our hospitals tell me that is something they have contemplated doing. PPE is still short. There is a plan for improving it. What our hospitals do right now is they are responsible for acquiring their own appropriate protective equipment. And if they have COVID cases and they're down to a 3-day supply or less, there is a state reserve. And for most of our items, we are more than a 15-day burn rate based on our current COVID plan. Delaying the peak has given us some time to train. You've all heard about needing to put COVID patients on a vent in a prone position. We are starting to train aggressively on that because it seems to be effective. But also, again, we talked about not every medical professional has done every kind of COVID response medical care. And so we're trying to incorporate that training. And really importantly, learning from others. For example, New York Presbyterian early on moved their ventilator management and their telemetry outside of the ICU so you could reduce the use of personal protective equipment. Getting that information to our hospitals, not that they did it the same way that Presbyterian did, but they thought about how they could do it. Can you reduce the entry and egress, donning and doffing? So looking ahead, our elective procedures are resuming. We don't know when we're going to see peak. The modeling looks like July. It looks like we're not going to overwhelm our ICUs, but all it takes is one high rise that has a slightly elderly population, and we could see some of our hospitals overwhelmed. You're talking about hospital finances. That is going to be a concern for years and years to come. We had 27 critical access hospitals underwater last year in a pretty good year, and with $13.2 billion in losses and people being still hesitant to go back into medical care. We don't know what those hospitals are going to look like. One of the risks in a rural metro healthcare system as we have now, a lot of the decisions might work for metro, they might not work for rural, but those small towns that have a hospital, that is the lifeblood of their community. They have their school, their hospitals, and their churches. If we lose those hospitals, it fundamentally changes the face of that community for years to come. There's been a lot of consolidation in the healthcare industry. Obviously, that will accelerate. Some things that we are doing still, legislative session ends on Sunday at midnight. We are looking at pushing through the increased FMAP, make sure it's going to providers and not just to support state programs at DHS or to support items the commissioner would direct to, not being applied to our capitation rates, but a direct increase to, in particular, children's hospitals who were not eligible for the first round of Medicare-based supports, and then our rural hospitals, but also dentistry. We've had a really tough time getting dentists being willing to take MA. So we're looking at using FMAP for those things. And then we are moving liability protection for healthcare workers and trying to work the details out on that so that as hospitals and the professionals that practice in them are faced with COVID patients and there isn't an accepted standard of care, we are reassuring them that as an elected official, we stand with them. We know they're going to make hard decisions. We believe they're going to act in good faith. And when they do that, we're going to be there to support them. So those are the things we have just a few days left, and those are the things we're going to try to get done as part of our COVID response here in Minnesota. So happy to answer questions.
Thank you so much, Senator Benson. And thank you to all of our speakers. I think we're right at time, so I may wrap up, but I did send in the audience chat my email address, and I welcome anybody to email me their questions for any of our presenters, and I can, if the presenters are willing, I'm happy to follow up with them for responses. I'm sorry we didn't have enough time for questions at the end, but thank you all so much for joining us today. I want to thank everyone for your participation and to our speakers especially for sharing their expertise and insights. And I also want to thank again the Commonwealth Fund for their support. I'd also like to point our attendees to the additional resources shared on this slide. And at the conclusion of this webinar, a very short survey will pop up on your screen. We really appreciate you taking the time to provide your feedback. Again, this webinar and other COVID-19 resources for states can be found on our website at ncsl.org. Thank you all so much and have a wonderful day.